Доброго ранку.
Good morning, everyone. Good morning, dear colleagues. We are starting the second day of the conference, a lot of readings, a lot of memorial lectures. We are inviting Andriy Ivanovich Kovalyov, medical sciences doctor, manager of ILAS Center, with his report, Dysmetorexis without endothelial keratoplasty with different diameters for treatment of endothelial Fuchs dystrophy. Good morning, dear colleagues. Unfortunately, I don't have any financial interest in the present report. So, we all know that Fuchs endothelial corneal dystrophy is the most widespread corneal dystrophy type, and some researchers say that we find up to 6% of Fuchs dystrophy in patients 40 plus years old. Definitely, it does not all manifest itself clinically. Until recent time, surgical treatment of Fuchs dystrophy was only with help of corneal transplant. But in 2016, we heard about a very interesting report by Catherine Colby, who reported about her first experience with the use of dysmetorexis, meaning removal of descemet membrane along with the damaged layer of endothelial cells for treatment of Fuchs dystrophy. It's understood that she was not the first who saw this interesting phenomenon like improvement of corneal condition after removal of descent membrane. So this is her report made by Catherine. This is the report mentioned by Catherine herself in her research, which inspired her to do her work. In this report, some scientists noticed improvement of corneal condition right in the place where graft was rejected, detached. So you can see the detachment of the graft, but the condition of the cornea is much better in the area where the graft attaches to the cornea. There was a number of similar researches about this phenomenon, but some of them were done in the beginning of the century. Based on these researches, we understood the pathophysiology of development of endothelial Fuchs dystrophy, and we obtained new type of surgical treatment which has several names, dysmetorexis without additional descemet stripping only. And it is interesting that, let's say, I always say the victory has many fathers, and losing is always like an orphan. So, because this is kind of a new surgical treatment, it is really efficient. Here is another publication found by me in a French journal. It is stated there that first dysmetorexis was performed by Louis Boufic, French scientist, French physician, who noticed that the cornea condition improved after removal of descemet membrane. And we understood that removal of descemet membrane was like a first stage to grafting cornea. After removal of descent membrane, he noticed that the edema was decreasing, which was indeed exciting. So, excuse me. Fine. So today it is considered that the density of the residuals, let us say, in the periphery of the endothelial cells has to be not less than 1,000, 1,500 cells per square millimeter. I'm sorry, something's wrong with the screen. So for now, we consider that not only the number of cells is of importance, but also the number of preserved hexagonal cells, meaning live, active endothelial cells. You have seen this video already, so I will not go into details here. So one thing which I should mention is that storage of functions after decimeterexis takes a long time and usually several months. The first month, like you see on the slide, we still observe corneal edema. This is how it looks like after 1 month as a rule. During the second and third months, we already see the improvements of the corneal condition. There is no edema. Cornea has restored its normal condition. And after 3 months, we can even count the endothelial cells in the central part. Like in this OCT scan, we can see the edge of decimeter-axis. This is the peripheral part where the decimet membrane was kept on the posterior surface of stroma. This is our experience today. We have operated 24 eyes, 22 patients. The majority of them had decimeter-axis along with cataract removal, but for some of them it was a separate surgery. 9 eyes had great decimeter-axis, not the type that is considered safe, because we observed complications on these eyes closer to the periphery. So here are our results presented on this slide. 20 patients, like all of them except 2, had improvement of their visual functions and condition of the cornea. Surely patients after decimeter-axis with the larger diameter had restoration recovery time longer than others, so we didn't even question that. But these 2 patients where we failed to obtain the result from decimeter-axis and we had to do following grafting of cornea. So these 2 patients with decimeter-axis had over 4 millimeters decimeter-axis, and in the periphery they had enough density of endothelial cells. So according to all the parameters, there were good candidates for decimeterexis, but after we did it, we saw that there was an enough number of changes, the changes in epithelium which spread to the peripheral part of the cornea. So that is why we concluded that decimeterexis is enough safe and effective surgery. Enlargement of diameter of decimeter erectus does not significantly impact the final result. Yes, it does impact the period of recovery, but not the result. For today, we still have some questions to answer. First of all, the diameter of decimeter axis. What should it be? The second is the number of cells of an endothelium which remain in the periphery. Does it impact the result or not? Does it impact the number of changes, meaning the live and most active cells? We are speaking about the live and most active cells. And now we widely apply confocal microscopy for this kind of examinations, particularly, and with help of these researchers. Yeah, 1 minute, please. I have to switch my presentation to the newest. The newest. Andrei Ivanovich, thank you very much. You have presented a great report. Everything was wonderful. Yes, but I would like to present just one more result. Fine. Thank you. Yes, unfortunately, I had a newer version of my presentation with confocal microscopy results. We saw really clearly how endothelium changed and the posterior stroma of cornea in more spread goods changes. And even after decimeterexis, we were able to see if there were changes good or not. And for today, we consider it one of the crucial criteria of success of decimeterexis, the lack of certain number of goods, particularly in periphery of the endothelium of cornea. Thank you very much for your attention. Thank you for your nice report. I think we will discuss it after the report. So we invite the next participant.
So we invite Olena Muzhichuk, the head of the Hospital of Multi-Field Hospital with a report, keratitis and steroids, be or not to be. So, Olena Pavlovna, you're welcome. Morning, dear colleagues. I want to present my report, keratitis and steroids, be or not to be. We all know that cornea is the most sensitive part of the eye. It should be transparent all the time, and if there are opaques, it is the indication for pathology. Relevance: keratitis takes 4 to 7% of all inflammations and can cause irreversible loss of vision, so we should treat them at the beginning. We know that as to their origin, there can be exogenic traumatic keratitis, keratitis provoked by conjunctiva, diseases and androgenic keratitis. Here we can see infection, syphilitic TB, and herpetic, then herpetic and of unknown origin. About as far to um, remind you, we should use antibiotics in order to prevent from flora, antiseptics, epithelializers, vitamins, anti-inflammation, and anti-steroid medications. But we all know the peculiarities of corticosteroid drops in ophthalmology. First of all, they are contradicted when we have surface keratitis. Uh, they stop healing. They are recommended on short term, and one of the complications is the increase of IOP and steroid glaucoma development. And then they decrease local immune response and risk of local complications. When we have infection processes, we should use them with the precautions. But such a scheme with the corticosteroids provoke that in difficult and long-term situations, despite all the complications, we use corticosteroids. The goal of our research is whether we should use steroid anti-inflammation medication in keratitis. Neurotrophic keratitis are characterized by a decrease in cornea sensitivity. So we have them after burns, after some diseases, and people suffer diabetes. We choose some clinical cases with neurotrophic keratitis. Here you can see the patient with neurodegenerative keratitis, and he was treated with dexamethasone in drops and medication to improve the condition of my bone glands. Then the next case is neurodegenerative age keratitis. There was complications on rash and redness of eyes. There was changes of conjunctiva and changes of the right eye. Paralimbal conjunctiva was loose and non-even. There were no infiltration in right eye. Here you can see his visual acuity on OD and OC, and in 7 days you can see changes in OC. It increases, but here you can see the dynamics on cornea and general improvement of patient's conditions. As a treatment, we used azithromycin during 3 days, dexamethasone solution without conservants, cyclosporin A 2 times a day, and trehalose solution 3% 3 times a day. Now he continues taking treatment. For now, dexamethasone solution and trehalose solution. His condition is stable. This case is under our supervision for more than 2 years. This patient referred to us in June 2023. Before this, he was in another center. Here you can see her administration. Among her administration from February to June 2023, you can see antiseptics, non-steroid anti-inflammation medication that can provoke problems with the cornea. Even dexpantanol that should improve the condition of cornea, but due to its combination provokes such a condition as you see on this slide. Uh, Visual acuity OD was the movement of fingers near her face. So we stop taking all the drops. We prescribed dexamethasone in drops and triagalose. It was her treatment from June to September. Her condition has been improving. In September, we decided to change the treatment and we added dexamethasone in gel form. Her condition decreased, worsened. She had problems with epithelium. Here you can see on this slide our steps of this patient treatment. As far as I mentioned, she's under our supervision and she has scleromyelation on 9 hour. She has a systemic joint disease, so it's a complex treatment, not only of keratitis. Taking into consideration scleromyelation, she was performed a surgery, and in postoperative period, non-steroid anti-inflammation drops were prescribed, and we stopped dropping in 2 days because cornea condition was worsening. Then the next step was deepithelialization in order to improve the epithelium condition. Here you can see condition before and after. And now she continues getting dexamethasone 1 time a day and combination of triagaloses with the hyaluronic acid 2 times a day because such a treatment stabilizes her condition. Our conclusions. Neurodegenerative keratitis. These are conditions of cornea that decreases the cornea sensitivity. Dexamethasone in form of eye drops improves the condition of cornea and is necessary in all these cases. Even if we use for a long time, IOP was within normal range, and we used it for more than 2 years. It didn't provoke glaucoma. We should use non-conservative drops with different mechanisms of action, and then your patients will have a long-term results. Thank you very much for such an interesting report and very difficult clinical case. All our questions in the end of our session. The next report is the
Capsulorhexis dosage features in phacoemulsification with femtosecond support in combination with anti-glaucoma surgery. So we are going to speak about glaucoma cataract. Glaucoma takes the leading positions in the structure of irreversible blindness, both in Ukraine and in the whole world. So this is why it remains one of the biggest problems of modern ophthalmology. Combination of glaucoma with cataract, according to scientific data, may reach 20%. That is why in modern ophthalmic surgery it is very actual. Capsulorhexis is one of important stages of phacoemulsification surgery because it affects the postoperative result. A clinical case, patient 67 years old, first primary, second A glaucoma, compensated, non-stabilized, myopic astigmatism, right eye artifactic, left eye complicated cataract. The visual acuity you can see on this slide with the normal intraocular pressure 18 and 20 millimeters mercury on both eyes. So which tests have we performed? We performed keratotopography, we performed endothelial biomicroscopy, we performed gonioscopy of the left eye, all the structures visualized. In accordance with the statistic perimetry, we found depression in the upper parts of both eyes. OCT showed thinning of nerve tissues layer, mostly in lower parts. We planned our surgery in Argus guided system, the optical biometry, the keratometry, calculation of optical power of the IOL. Phacoemulsification was planned by us, femtosecond following capsulorhexis of 5 millimeters, anti-glaucoma operation, non-penetrative deep sclerectomy. We used surgical systems Stellaris Elite and microscope. We used femtosecond laser lens X, which helped us to perform 3 stages: the sections of cornea, the capsulorhexis, and fragmentation of the lens nucleus. And here is the video of our clinical case. We started sections, the diameter of capsulorhexis and fragmentation of the nucleus. We installed, preset these settings, capsulorhexis, fragmentation of the nucleus in the video you can see now, and sections, the basic section and side ones, parasynthesis. Later stage was in the surgical hall. We renewed the measurements, hemostasis, forming of 2 scleral flaps, the superficial one and the deep one, in according with the classic technique of sclerectomy. Deeper flap was formed. Later was the stage of cataract surgery. Administration of viscoelastic, natrium hyaluronate. We don't paint it with blue. We just use forceps to remove the capsulorhexis, which is visible really well in accordance with the plan. Fragmented lens nucleus was removed then. Irrigation of the lens mass. Then viscoelastic material and implantation of secondary lens. which was set along the axis of the stronger meridian of the cornea. The next stage, the finishing of anti-glaucoma operation, the removal of the flap, formation of goniodecimate hole, and removal of juxtacanicular tissue. Fixing sutures on the flap, sutures on conjunctiva, as a result, one day after the surgery, visual acuity left eye 0.5 with diaphragm 0.7, slight edema of cornea, intraocular pressure of the operated eye 19 millimeters, mercury without drops. Thank you for your attention. Thank you for the interesting report.
Thank you very much for your interesting report. And the next report, please. Andrei Sergeyevich Yevtushenko, dislocation of lens and IOL fixation, how to solve the puzzle. Good day, dear colleagues. Thank you very much for those who are here sitting in this hall. So the problem is really very relevant for now because there are standard situation inborn conditions when we have glaucoma uveitis for today. We have a war and a lot of post-traumatic pathology of such etiology. So this surgery is very widespread. What should we do in the surgery of dislocation? How should we solve this issue? It's extraction of cataract and fixation. We had a lot of options, but the main is focal emulsification if we can preserve the sac, or lens vitrectomy. When we have a full dislocation, there are a lot of classifications. We want to discuss them in details. In a struggle for sac, if surgeon is able to preserve it, of course it is necessary to do it. It will be your super goal and super task. An ideal option, there are a lot of devices, rings, hooks, in order to help surgeon to preserve sac intraoperatively. Here you can see a short video I want to present you. We see here a post-traumatic dislocation with a falling out of vitreous body fibers. But in this situation, I decided to preserve sac and then to operate to install IOL. Here you can see this serious moment capsular axis in order to do it in proper measurements, because we have to fix this device at the edges of capsular axis. This video was made 5 years ago. We fixed it with a polypropylene 10 zeros. We sutured it with the help of propylene sclerally without sutures, then sclerosification and grafting. Today we use the same technique, but we use sutureless flange fixation. Technically it is the same. Here you can see the image of our surgery. So we managed to resolve this issue. When we have dislocations in vitreous body, we have two options. We can use peftodektylin to grow and to lift and to use emulsification. It's also an old video where we show you fixation of IOL to iris of usual IOL. For today, we don't perform it in a scheduled way because there are a lot of different options, but for that time it was our usual strategy. What about scleral fixation? I think that for today this fixation is an ideal option of fixation. We began to use it with the beginning of 1990s. There were lots of techniques. But as to my point of view, scleral fixation of IOL uh, as to Cannabrov is the methodology that is the most relevant both for patients and for surgeons. I believe that a lot of specialists use such a technique. It is simple and we have good results. I think that we should resolve this puzzle in such a way. Uh, we remove a lens if we have a dislocation. We use phaco emulsification. Then we graft special lenses, 4-point. Now we have a lot of companies that manufacture those lenses. Uh, as far as I know, Tortis is presented here. This lens of good quality, and you can see flange fixation. So you don't need special additional devices, normal usual coagulators, and Prolene 6 zeros. We try to use 7 zeros, but it is too weak and it is difficult to graft to this hole. So we centered it step by step. Try not to strengthen in order not to prevent a scleral deformation, and then immerse the edges under conjunctiva. Now we have a lot of variation of those techniques with scleral pockets, but you can do it in such a classical way and we have a perfect results. It is important, crucially important to do it in up and down, because you can see these two blue drops. Thank you very much for your attention, Andrei Sergeyevich. Thank you very much for your interesting report. It is very short, but we have one notice. If we are talking about methodologies, techniques, so please let's start with a person who launched this technique. It's not Konoprov, but externalization. It's Yamani technique. He launched and then Konoprov made his own modification. If you use 6 zeros, it's not Konoprov, it's Asia. So please, let's be precise and let's have an honest approach to our authors. Thank you very much. One more time. The next report.
The next report is from Dmitro Gennadievich online. Dmitro Gennadievich Zhabayedov, medical science doctor, ophthalmological department head in University of Bogomolets, with the report about characteristics of the new method of sutureless scleral fixation of the IOL. Good morning, everyone. Greetings, dear colleagues. I will show you my video on the topic with one suture surgery. We have the previously placed capsular ring in the sac. The patient has suspicion of Martesania syndrome. The surgery was on one eye, and we observed misplacement, decrease of size, and deformation of the lens. We had pretty the patient we fixed the patient without any problems. We used two parasynthesis in opposite sectors and basic section of 2.2 millimeters, and accessed the anterior chamber without difficulties. We painted with trypan blue, making it clearly visible. It is especially important in case if there is some weakness, because it allows us to control the further manipulations. The viscoelastic keeps the anterior chamber. We performed capsular access and implanted the capsule ring, which distributes the tension around all the circle of the sac, which is indeed important because of the deformation and decreased size of the lens. In order to remove the vitreal tissues which might penetrate the anterior chamber and cause tractions, we performed anterior vitrectomy, preventing complications and allowing for stability of the capsular sac. We prepared the fixation system, polypropylene thread, burning it to form flannel. The pressed parts of the flannel, we pierced it. 27 caliber needle, might be smaller, probably better. The thread later is pierced through the hole. This is a nice system of fixation, minimizing the risk of misplacing. Fixation half ring is placed in the anterior chamber, connected with the polypropylene thread. Later, through the sclera, 2 millimeters from the limbus, we perform transscleral piercing with 20 caliber needle. The free end of the thread is taken outside. With help of forceps, the half ring is placed in the sac pulling the thread, providing for stable positioning of the ring. At this stage, it is extremely important to provide for stability in order to protect the epithelium of the cornea. The surgeon has to be experienced and manipulate with tools in both hands, pulling the suture in a balanced way. Also, it is necessary to control the intraocular pressure and avoid tension. Modern viscoelastic helps with it. It works for the safety and stability of the manipulations. In the zone in sclera, the thread is cut, leaving the end with length of up to 2 millimeters. This end is later burned, forming the flannel, and this flannel remains on the surface of sclera, thus providing for good fixation. Then we dissect and facilitate further phacoemulsification. Now we start phacoemulsification. We found the right parameters and performed phacoemulsification for less than a minute. The most important thing was to avoid damaging the posterior parts. It depends on factors of density of the nucleus and stability of the capsule sacs. That is why the surgeon has to work really carefully, evaluating every movement, which is most important in cases if the zonular apparatus is weak. So now we are polishing the capsule sac, decreasing the risk of secondary cataract development. And now we are implanting the intraocular lens with 4-point fixation. In order to hermetize the anterior chamber, we hydratate. The conjunctiva then is under tension to hide the flannel and to protect the fixing element. This technique of flannel fixation creates no flap. It provides for opportunity to perform complicated operations. Thank you very much for your attention.
Дмитро Геннадійович, дуже дякую.
Dmytro Gennadievich, thank you very much for such an interesting clinical case. And then we continue with our final report. Irina Mykolaievna Beskarovana, Doctor of Medical Sciences, Professor of Poltava Clinical Hospital, with a report long-term glaucoma control, myth or reality. Dear colleagues, dear organizers and participants of this honored conference, despite of my report not being in glaucoma section, I'm sure that you've heard about the relevance of this problem. And it is the problem that provoke blindness. And of course, you know about the increased IOP. Such an information we have in guidelines on glaucoma, both in European guidelines and Ukrainian guidelines. The goal of treatment is to decrease the IOP and to um, to provide their good quality of light. When we work with the glaucoma patients, so we have an interest to analyze the stability of glaucoma process in 108%. Uh, they were treated for a certain time. Unfortunately, in our group, more than 82% has a decreased condition of vision functions as to their own feelings or to the clinical data, but visual field was examined only within half of our patients, and in 14% we use perimetry. Dynamics has only 7%, and optic tomography was in 67% of patients, and only 6% make OCT every year. Of course, we examined them every time, every year, but it was different time, and of course, we were not able to make certain conclusions. So very often, we saw in electronic history blurred circles, and it was very difficult to identify. In guidelines, we can see algorithm of glaucoma treatment. Therapy starts with mono medication, first line, medication of first line, and then we have uh, target pressure and how to decrease IOP to reach our target goal. Our our views. Some patients began to take two or three medication, and there was no reachment of target pressure. Of course, it influenced not only on glaucoma but on general patient's condition and its readiness to get treatment. And also in our terminology, we have a table with the medication effectiveness as to their hypertensive action. It, it is crucial for practical physicians to know such an information that decrease IOP by 30% and more can preserve vision functions for long-term time, and prostaglandin analogs can give us such an effect. But pathogenetic peculiarities of glaucoma can be treated with medications to decrease the liquid inside the ball, and we have to use beta blockaders. Then we should know the complication and possible side effects of medications, because we have old age patients with glaucoma, and of course a lot of complications on the anterior surface of eyes were described by a lot of scientists, and a widespread problem of eye dry is covered in many countries and is connected to usage of uh, medications with the preservatives. I want to give you some clinical cases of OCT of patient with glaucoma for more than 6 years. IOP before treatment was within normal range. Visual acuity 1. Computer perimetry was the dilation of blind spot deepening of excavation, dislocation of vessel nodule, and thinning of paraepithelial layer of retina. But the treatment provokes complications in this patient that during all these 6 years that patient was abroad, was a participant of war events, but we have the same parameters. So this treatment helps him. Example of patient with glaucoma for more than 80 years. IOP before treatment was moderate uh, with a primary stage, visual acuity 1, but in statistical parametry we can see nasal step. So she used beta blockators that didn't help to stabilize her. Then we began to use analogies of prostaglandins and decrease IOP up to 20 millimeters of HV. And we can see good visual effect, but she had some cataractal changes with the time. And I thought one clinical case of patient with pseudoepholical glaucoma at the beginning of before treatment. It was increasement of IOP up to 45. Treatment was ineffective, and 5 years ago surgery was performed. IOP was within normal range up to 18.5. Visual acuity is on slide. It is preserved for now. But as to the OCT, visual functions has decreased, worsening. It is difficult for him to drive a car and to make some household things. When we are talking about this patient, I want to recommend you not only to decrease IOP, but to use a neuroprotector therapy. So the treatment of glaucoma, a patient requires control of IOP, visual functions, and development of neuropathy control. You have to be awareness of relevant protocols and guidelines on glaucoma treatment. It was my report in order to make a conclusion that it is necessary to highlight in our conference that glaucoma should be supervised on outpatient level. It is recommended to control visual acuity with the different devices to control the condition of optic nerve one time in 6 months. Thank you very much for your attention. I have no financial interests. Irina Mikolaevna, thank you very much. Our section is practically over. We are practically not out of the time. Thank you very much to all our speakers for your interesting reports, for time, efforts you have spent for preparation, to all our participants, and your experience that you share with us. And we have one moment. Thank you very much to you all listeners, colleagues. First of all, I want to thank our defenders who defend us and who give us this possibility to conduct this conference despite of our war state and war events, to have such an interesting conferences, to make our duties. So glory to Ukraine. Glory to heroes. Thank you to our defenders. And the last moment, I think that all the participants that deep we we will give Andrei Ivanovich the diploma. We will award him for dexametarexis. I think that you are not against it, and he was the best within this session. Thank you very much. Session is over. Thank you. Good day and continue fruitful continuation.